Hello everybody. Today we are going to discuss about intermediate syndrome. The organophosphorus insecticide causes three clinically distinct disease entities. In order of appearance after exposure to the OP, these are acute cholinergic syndrome, the intermediate syndrome, and the OP-induced delayed polyneuropathy. The acute cholinergic syndrome is the manifestation of acute exposure of OP compound and was quickly recognized following introduction of the OP pesticide after World War II. It is caused predominantly by the accumulation of acetylcholine, which is the result of phosphorylation and inactivation of acetylcholine esterase, the enzyme responsible for hydrolyzing acetylcholine at the site of cholinergic neurotransmission. So OP-induced delayed polyneuropathy has been clinically observed and documented for more than 100 years. The pathogenesis of this clinical entity is still not entirely clear, but OP poison-induced delayed polyneuropathy is associated with and possibly caused by inhibition and aging of neuropathy target esterase. So OP-induced delayed polyneuropathy is not a cholinergic phenomenon. Intermediate syndrome was first described in Sri Lanka in late 1980s and had subsequently reported worldwide, but the pathogenesis and the factors that influences its occurrence in approximately 20% of subjects who have ingested OP are yet to be clearly defined. The syndrome differs from the acute cholinergic syndrome clinically in the muscarinic syndrome and signs do not occur. So this intermediate syndrome is different from the cholinergic syndrome and the opioid-induced delayed polyneuropathy. The onset of intermediate syndrome is the later than the onset of acute cholinergic syndrome in relation to the exposure to the OP poison. So IMS is also differ from the OP poison induced delayed neuropathy in that paralysis is proximal and the upper motor neuron symptoms and signs do not occur. Whereas in the OP poison induced delayed polyneuropathy, paralysis tends to affect long axon and there is CNS component. Furthermore, OP poison induced delayed polyneuropathy occurs later after exposure to the OP poisoning than does intermediate syndrome. Consciousness is usually unaffected during intermediate syndrome and OP poison induced delayed polyneuropathy, but may be impaired during acute cholinergic syndrome. Fasciculations may be observed during acute cholinergic syndrome, but not the intermediate syndrome and OP poison induced delayed polyneuropathy. Thus, it is clear that intermediate syndrome is the separate syndrome from both acute cholinergic syndrome and from OP poisoning induced delayed polyneuropathy. Now about mechanism, intermediate syndrome is well recognized as the disorder of neuromuscular junction. However, its exact underlying mechanism is not clearly defined. Downregulation and the desensitization of polysynaptic postsynaptic acetylcholine receptor after prolonged acetylcholine stimulation would explain the occurrence of intermediate syndrome. Oxidative cellular damage to the muscle membrane could be another possible mechanism of muscle necrosis. Clinically, John et al. Demonstrated an association between increased blood muscle enzyme, that is creatinine phosphokinase and lactate dehydrogenase, and development of intermediate syndrome, which also supported the role of muscle injury in intermediate syndrome. Different susceptibility of the various cholinergic receptor or inadequate oxime therapy played a role in the development of intermediate syndrome, if intermediate syndrome did exist. This intermediate syndrome could be due to reduction in the number of functioning acetylcholine esterase receptor at post-junctional membrane or failure of acetylcholine release. Now about clinical feature. Following exposure to the various organophosphate insecticide, clinical manifestation of IMS typically occurs within 24 to 96 hours and affect conscious patient without fasciculation or other cholinergic sign. Marked weakness of neck flexion and the varying degree of proximal limb muscle weakness, manifesting as weakness of shoulder adduction and the hip flexion, are the constant clinical feature. Respiratory insufficiency is also common and it frequently draws the medical attention to the onset of syndrome. Other possible manifestations are involvement of muscles innervated by motor cranial nerve and decreased deep tendon reflex. Sensory impairment is not clinical manifestation of IMS. With appropriate therapy, recovery from IMS occurs 5 to 18 days after onset of weakness. The regression of toxic signs among patients who survived IMS following distinct pattern. Muscle power first resumed in the cranial nerve innervated muscle, followed by respiratory muscles, proximal muscles, and the neck flexion. The onset of IMS in that study ranged from 7 to 75 hours post exposure and lasted between 6 to 6 and 30 days. Finding on the risk factor of IMS also differed among the studies. Although IMS generally occur among patients with prolonged and the severe inhibition of acetylcholinesterase, not every patient with severe inhibition of enzyme develop IMS. There were other risk factors for IMS as well, including delayed metabolism of organophosphates due to toxicokinetic factors of the insecticide or impaired organ function, severity of poisoning, elevated muscle enzyme, and inadequate or late oxime therapy. IMS is also linked preferentially to patients' exposure to specific organophosphate, namely phenethione, dimethoate, and the monocrotophos, all of which are dimethoxy compounds. However, IMS was not limited to the patient and with exposure to this organophosphate. Parathione and combined ethyl parathione and methyl parathione, methaimidophos, and the dichloros, and various other organophosphate insecticide have all been implicated in the development of IMS. Now, electrophysiological finding. Electrophysiological study have been proposed as a specific diagnostic tool for patients with the IMS. Finding of electrophysiological studies in patients with IMS did not yield a consistent result. Tetanic stimulation of abductor pollicis brevis muscle showed marked fade at 20 Hz and 50 Hz, and there was no post-tetanic fasciculation. In contrast, the D. Blicker et al. Demonstrated early decrement at low frequencies of stimulation with normal series at 10, 20, and 50 Hz or decrement at intermediate frequencies, that is 10 to 20 Hz, with normal finding at both low and the 50 Hz frequency. A few days later, after poisoning, either mild decrement increment phenomenon at high frequencies, that is 20 or 50 Hz, or isolated increment up to 220% at 20 or 10 or 20 Hz were recorded. Neither increment nor decrement after repetitive stimulation was shown in case reported by Sedgwick and the Senaki. Some patients had amplitude decrement at frequencies of 10, 20, and 30 Hz. In the early phase of IMS, decrement increment pattern at 10 to 30 Hz was detected. With clinical progression, decrement increment pattern was noted at low frequency, which then changed to severe decrement, mostly at higher frequency among patients with severe IMS. Because decrement increment phenomenon at intermediate and high frequencies were found among patients manifesting muscle weakness who did not develop classical IMS. So about management, IMS carries the high risk of death among patients with respiratory failure. Therefore, prompt recognition of syndrome is the cornerstone of IMS management. Treatment of the IMS per se is mainly supportive, and there are no specific antidote available for this devastating syndrome. Nevertheless, because the IMS generally concur with the severe organophosphate toxicity and persistent inhibition of acetylcholinesterase, early aggressive gastrointestinal decontamination followed by appropriate therapy of atropine and oxime and the prompt institution of ventilatory support should be helpful in ameliorating the magnitude and the incidence of IMS. Therapy with the obidoxime, a more potent oxime compared to the pralidoxime, significantly decrease the incidence of respiratory failure, the length of hospitalization, and mortality. Thank you, guys.